Assalamu alaikum. Welcome everyone on board. From today, we will just try to start dissecting our anesthesia discussions in slightly different way. Few sessions I will take, but then how to extract the knowledge when you are preparing for an MCQs based exam. Basically, because uh, there are two different ways of studies. One is prospective way and one is retrospective way. In prospective way, the way of study, actually what we do, that we are just trying to read a text from any specific book, and we are just expecting that whatever uh, high yield points we need to know, we will be able to answer through from the knowledge which we have got from that page. In my opinion, there are different school of thoughts, but I think the way we are in this era, our mind is not in the way which it was maybe 20, 30, or 50 years ago. Now things are different. And I give you an example that there was no Google Map. Okay. So we used to learn uh, a way to reach some place by our memory and by the fact that we will go for 1 kilometer or for 5 minutes by walking to such certain place, and then will we saw some landmark, and then we will turn to the right or left, and we used to reach. Okay, but now one of my very close friend, he used to say that even I go to bathroom via Google Map. So why it's so? Because now our um, our approach to a number of things have been changed. So personally, because we are from a hybrid era, that we are not too young and not we are not too old. So I will suggest that retrospective way in which you create the questions and find out a way. That's always much more uh, better way. Okay, so this is one point of my discussion, that we should try whatever we are reading. First of all, we should try to make some goals out of that topic, and then try to find out the answers to that questions or goals beforehand. Okay, rather than just reading blindly. This is one point. And other point is that whenever we are reading some text, we try to gather points. Okay. That what points we are gathering from that specific MCQ or says. Because in MCQs, there are two different types. In majority place, maybe 30, 20, 30 years ago, even in British exam, they used to have more of multiple true false, MTFs. So every statement has to be read and to be answered as yes or no, or you can say true or false. Okay. So, but recently, in even in for CA and Irish Fellowship exam, they have replaced it with that choose the best. So, choose the best actually gives you more better approach, and multiple true false questions. Still, I will suggest you that whether your exam is just in the pattern of choose the best, but the way you can extract knowledge from true multiple true false as points, as building blocks, they will serve as a raindrops. Okay, so one by one you will build up your knowledge. And if you read, for example, 50 questions, you will find 250 stems. So 250 stems you will find, or sorry, not the stem will be 50, but 250 options. So actually uh, point, each statement will give you some knowledge. So another way is that you build up your knowledge, and that was my way. Even when I appeared in a number of international exams, so because after finishing my fellowship, the first exam which I appeared was European Diploma in Anesthesia. And European Diploma in Anesthesia is very simple exam, true false, and you just have to identify clearly that statement is right or that statement is wrong. So it is easy in that way that you can judge the statement, but difficult in that way that in MCQ, maybe you are asking that what is the correct option. Maybe you pick it and you have no idea about other options. Even then you can get the score. But in true false, actually you should be knowing everything. Actually, yes, it is the margin of error is a different way that in multiple true false, either you will be right or you will be wrong. But in choose the way which they are asking you is the best approach. Either it will be the next step to do, the best step to do. Answer may be different. Maybe next step is to do is something else, but the best step to do is something else. So these two will be different questions or different points. So that is major difference between multiple true false versus choose the best. But still, I will suggest you that even if you are preparing for any exam, choose the best. Yes, you have to be bullseye. But still, if you want to build up your knowledge, multiple true false will give you a lot of knowledge. Of course, it will look like actually, it will more like a text, but with a text which you are reading with some objective. So that is the basic difference. And actually, because another statement which I say that in a number of exams, there is written part and there is oral part. Unfortunately, the people, majority of people dissect it and say, okay, sir, let's pass the written part and we will prepare for oral part later on. But actually, this is wrong because if you are able to express your knowledge, so my statement will be that the day when you are appearing in the written part, if you have the knowledge that someone takes your oral part and you pass it, that day you will not fail in written. I repeat, the day at which you are appearing in your written part, because written part may be different, MCQs based or SAQs, or now there is another terminology which there is CRQs. Okay, because there is an SAQs and then there is SEQs, and this is constructive response questions. So actually, this is the most modern way which is being used in like FRCA or FCAI, Fellow College of Anesthetists exam. So this is a wonderful way. Okay, because they will be asking you a pinpoint. Maybe your answer will be in numbers, but it will be enumerate something, different options, different ways. So the answers are very short. Okay, and then they are asking your critical development of critical thinking, and you are answering in points. So my the thing is that if you prepare in a way that your knowledge is that you are integrating the written and oral, you are not segregating it, and you are integrating that you are preparing in a way that the day of written should be day of your oral exam. This is my humble request. So if you will prepare like that, because more the people back in Pakistan, or even if you are preparing for any exam other than the licensing exams for Saudi Commission or DHA or something, there are isolated example for that thing. Otherwise, even if you are appearing in FCI or FRCA, even if you have passed the written, you have to appear in Viva or oral part. Similarly, if you are in Pakistan and you are doing FCPS or MCPS, or you are India, you are doing MD or DNB, you will have a written and then you have a Viva. So for basic message for you guys will be that you prepare together. Another advice I will tell, when we will go back, move to what I want to tell you, that how you should interpret your knowledge or how you should read, how you should read MCQs. But I will tell you that another advice I will have to you, that make audio notes. Okay, because before we used to make notes by our writing. So but now again, this is to 2025. So my suggestion to you are, you guys, that whosoever you are preparing for any exam, whatever you are reading, whether you are reading an MCQ, whether you are reading any point, record it in your by your own voice in your mobile, label it day wise or topic wise, and make a folder in your mobile. And whenever you want to recall that in the whole day, you recorded, for example, 50 recordings of 30 seconds each. And now next day or after 2 days, you are sitting in a place where you cannot open the book to study, you can just put on the headphones and open you and listen to your own recordings. So that will be a revision. And that's a very effective way. I will highly recommend you guys to do this. Okay. And even if you are preparing together, maybe you can divide MCQs or divide the things, and you can share your recordings to your friends. Maybe you can make a WhatsApp group for this thing, and you can read one topic, make your own points. Even you can make it while reading, and then when you are listening to it, that will be a great way of revision, and that will help you in oral part as well. Okay. So this is the main point I want. Any question, any comment about my point of view with this reference? Um, s- s- okay, so actually this is the way. So now, for example, if we just start our point that, for example, we are reading this MCQ, you are called to anesthetize a claustrophobic patient, okay, who requires an MRI scan. So this word claustrophobia should be explored, and you should be knowing what is claustrophobia and what are the patients who will be at risk of claustrophobia. So you will find few points about what is claustrophobia and how it should be tackled. Similarly, MRI scan. So now, because a few of you are preparing for your oral part, so I will tell you that whenever, even if you are reading MCQ, you should think about MRI. Okay, MRI, what are the concerns in MRI? So the way which we revised for MRI, you can revise in your mind. Maybe you're not reading, but if you have thorough knowledge, or you can make your learning goals. So I have to understand what MRI is, what is the relationship between MRI and claustrophobia? So what are the problems? That there is a lot of noise, there is a closed cavity, okay? It's a very cold place. So patient has limited access, or all the things which are related to MRI. But you have to find a relationship between claustrophobia and MRI, okay? So this is something you just have to understand. Then the next point will be the patient has cervical fixation device in place to stabilize a recent C-spine fracture. So now another learning point for you, that in what conditions you need cervical fixation. What are different ways to that? There is a soft collar, there is a hard collar. Okay, how you place it. So things related to that thing, and then even you can think about it, what are the criteria for cervical spine clearance, how to manage airway in cervical spine. Like, these are learning goals. I know that it looks weird that what you are reading, you are not reading one topic, but if you explore or uh, this way, like tune your brain in that way, you will see the result after. If you are consistently reading like that, after maybe few months, you will realize that even in one MCQ, it will take maybe a lot of time, but gradually your time will decrease and your knowledge will build up. So that is what is required. Okay. So uh, this is how I suggest you to read. So now what they are saying, which of the following factors would most likely mean that an MRI scan is contraindicated? Okay. So they are asking about absolute contraindication of MRI. So now you can Google and see what are absolute contraindication for MRI. You can make a list. You will find a number of things, and in which condition MRI scan is contraindicated. Because Safullah, you are here, so I will give you a chance. What do you think? What are absolute contraindication of MRI before we go to the answer to this question?
Sir,
Safullah, are you
foreign body, metallic foreign body and eye
okay?
and brain uh, and inner ear,
Okay.
metallic foreign body.
You are missing something. Absolute contraindication will be one of the most important. Absolute contraindication will be, think about it.
Sir, if the patient
Patient denial.
itself
Patient
refuse,
denial. This is refusal. This
patient
patient,
refuse.
in the language of Saudi Arabia, patient is Mudir Kabir. And in Pakistan, we will say patient is Badshah, patient is king. Patient can refuse. Whatever you are planning, patient is not interested. So this is one of the contraindication. Okay. So and then the rest of the thing which you are saying, that it will be like contraindication. Okay. Then, because if why I am telling you this thing, that in all the books you will find it is written practice. Unfortunately, we are trying to make it a source that, okay, examiner will open this book and copy paste the question from here in the exam. It maybe it is, there is a chance that it happens, but this is not, this not should not be your objective. Okay, your objective should be that what knowledge you can get from this one MCQ. Okay, now let's go forward. So what are the options? The provision of a standard anesthetic machine in MRI suite. So, so this is a point, that what sort of machines are MRI compatible? Because journal machine will not have the thing which is compatible in the MRI suite. So this is one thing. Patient having permanent pacemaker in situ. So you can, when you are preparing for the final exam, this is a time for you to just, when you are reading in this MCQ, but at the same time you should just brainstorming, okay, what what are indications of permanent pacemaker, what finding you will get it in X-ray, what finding you will get it in ECG, what are different modes of pacemaker, like we discussed. So this will be, I know that you are doing this MCQ, but your brainstorming is giving you a lot of things. So the people who are preparing for the exam, I would suggest them to have your approach like this. I know it look weird and it will take a lot of time initially, but gradually you will come to know what is the advantage. Okay? Because when, if you have made mind like this, things will become much easier. For maybe initial 1 month will be very difficult. Maybe you are very slow. You are only focusing on one MCQ or two MCQ, but gradually it will increase the, okay. Okay, then the patient recalling that he has a foreign body in his eye. So another thing now, because this is a very rare thing, but still you can see what are various foreign bodies which are placed in the eye. What are the different indication? This is just a source of knowledge. The provision of standard infusion pumps in the MRI. So this option and this option seems to be almost the same. And then a halo device for cervical stabilization. So because you can, as I told you, that you can just have a look, what are various devices for cervical spine stabilization? What are various devices for cervical spine stabilization? How to do it? Okay. So then you will find that what is the role of halo. So actually, because I have read this book, so I knew the answer, that this is a foreign body in the eye. And maybe, for example, if it is any foreign body, because now even the foreign bodies which they place, some of them are of material which is MRI compatible. This is one point. And then there are certain MRI machines in which there is no claustrophobia even. There are some machines in which is open. I have not seen it, but there are something in which there are open MRI machines also, in which the at least the problem related to claustrophobia is not there. A lot of problems are there, but this problem will not be there. Okay, so now you will come to the explanation which is written in that specific book or that specific source. But as I mentioned to you, in one MCQ, so many points you get for claustrophobia, for revision of MRI, cervical spine clearance, cervical spine stabilization, challenges in cervical spine injury. Okay. And then what will be the indications of MRI in this scenario? Why they want to do MRI? Okay. And then you will go to this MRI compatible machines, MRI compatible equipment, the lines and everything which we actually few days ago we discussed. So we will just read out. MRI scans are often utilized for investigating the CNS as they provide images that that show improved distinction between tissue types compared with CT. So now in another point, you can just revise that what is difference between CT and MRI. Okay, what is the basic difference, what is the radiation problems, what are the advantages, how you interpret. I'm not very good in radiology, unfortunately, but you should, if you can identify that what is the difference, and how what is the difference in the appearance between CT scan and MRI. So this is another point you can revise when you are reading this line. Okay, MRI scanning advantage that atomic nuclei within tissue naturally spin, generating their own small magnetic field. By applying a large external field to a tissue, these spinning nuclei align with the field which has applied, like it will go to high level. A second external field is then pulsed in a perpendicular fashion, causing some nuclei to be pulled to an angle. This incorporates nuclear energy absorption and they begin to wobble or precess, a term used to describe rotation around an axis different to that of original spin. This is a very difficult text, but anyway, precession results in tissue producing rotational magnetic fields, the amplitude and specific frequency of which can be detected and used to form an image. That's what I explained, that one is fixed and one is switching on and switching off. When it is switching on, the nuclei goes to high level, and then when it is switching off, it returns to the previous level. This change is different in different tissues according to their pathology or physiology. Okay. As the nuclei return to their previous positions between pulses, they emit the energy they previously absorbed at the same frequency. The rate of their return depends on the element content of the nucleus, hydrogen or phosphorus, in addition to molecule of which it is part, water or fat. Okay. Different tissues, their type, therefore return at a different rates. By using a combination of magnetic field gradients and pulse configuration, detailed cross-sectional view can be obtained. So this is the actually a very nice, if you want to be an expert in how explaining, maybe, but the thing is that usually in our part of world, nobody will be asking MRI like this. They will not ask you about MRI in that way. But still, if you can understand, because I had made a concept with a simple words than what is written here, but the thing is the same. Then MRI scanners raise a number of safety concern with regards to equipment. As a magnetic field is constantly present, anything containing ferromagnetic material will be attached to it, turning them into projectiles. The field strength is measured in Tesla and Gauss. So this is also an MCQ point, that which is bigger unit. So 1 Tesla is equal to 10,000 Gauss. So MRI scanners for medical imaging are usually 1.5 Tesla, but sometimes 3 Tesla. The strength declines with distance from the magnet, and the contours are marked in Gauss lines on the floor. So it is the area which is safe, which is the area through which you can go. So beyond 5 Gauss line, no ferromagnetic material should be ever be taken. Okay. It includes all your anesthesia equipment, even your personal equipments. Another concern with regard to equipment is the effect of radio frequency energy resonating with material, causing the dispersion of energy as heat. The patient can therefore suffer burns. This is also troubleshooting case reports in which, when this happens, radio frequency energy, because radio frequency ablation is being used in a number of medical treatments. So that is the point which, why they can ask you in in Viva, or there may be a question that why this burn occur. So this is another point of your MCQ. Okay, that radio frequency energy resonating with material causing the dispersion of energy as heat. So this is the answer. Patient can therefore suffer burns from any conducting material which they with which they are in contact. So if they are touching something, they can cause the burn. Okay. As a result of the above, all equipment is classified according to the hazard it poses under certain conditions such as magnetic field strength or in view of radio frequency absorption. MRI safe equipment can be used in all MR settings, like MRs, which are equipment which is MR safe, can be taken in any MR place. MR conditional in specific environment, and MR unsafe is none of the aforementioned situation. Okay, so this is how you define it: MRI safe, MRI conditional, and MRI unsafe. Conditional will be that at certain area you can take it, and in certain area you cannot take it. So this is monitoring in MRI suit is essential and has evolved accordingly. MR compatible monitoring is standard, with many units using telemetric equipment to avoid any induced currents in long cables. MRI compatible anesthetic machines and infusion pumps are available. However, standard equipment can be used with extensions to beyond the 5G line. That's what we do a number of times. We are using the same machine, but they are relatively away. They are not entering in that area. The anesthetic machine must be securely fixed to the wall and pump attached to their extension through a port into the control room. Pacemakers and implanted cardiac defibrillators are at risk of malfunctioning or displacing. It can pull, it can cause damage. Okay. So were until recently a strict contraindication to have an MRI. Technology has, however, advanced, and there are some now MRI compatible models. These are also MRI strategies and guidelines that have been described to limit risk in event that an MRI is absolutely necessary for a patient with standard device. Okay. Cervical fixators such as Hoelo device vary in their classification. Some are MRI safe, and their hazard on the hazard of any other item can be easily checked by referring to a. So that's how. So you will find the you see, this is another point which I'm telling you, that any people who are appearing in Irish fellowship exam or FCI exam, actually this was the source, continued your education in anesthesia and critical care. And after a few years ago, they changed the name into BJA, British Journal of Anesthesia Education. So actually, I have arranged all the articles of BJ Education since their start to date. So we have all the articles arranged in the link which I share you to you guys year wise from I think 2001 to 2025. Every month they send, every month I download and I upload. Okay. So this is for your access all the time. Okay. So now I hope you understand that even in one MCQ, you learn so many things. So if you make objective, so you can make a word of claustrophobic, MRI, C-spine. So as I mentioned, this is the way for your studies. For any person who are preparing for your exam, okay, Doctor Strange. So anyone among you who volunteered for our, anyways. So I hope you understand. So let's go to next question. But actually, my purpose for you guys is to understand how to use these sources, because this was actually a easy question, very few learning points in it. Okay, but you will find in some question so many things I will ask you to think. Now let's come to this question, because here maybe you will find that, my god, what are you doing, what are you trying to do? Let's do it. Okay. So in this scenario, what's the thing? 77-year-old. Okay, let's revise the elderly. So you should revise the physiological, pharmacological, anatomical, and logistic consideration in a patient in elderly age group. And what is the change? What is the effect? How to manage change? Or you can make another point. What is the change and how it occurred? And what is the effect and how you manage? Okay. So whatever you read in the book about the physiological changes, about FRC, about closing capacity, about blunted adrenergic responses, about diminished renal function, diminished uh, like uh, uh, problems with the positioning, problem with the IV line, problem with the consent, problem with the delirium, problem with hearing, visual problems, making the positions so you can revise. I know initially you will leave this topic of this you will leave this MCQ and open the topic of elderly, but maybe after some time you already know, and you are just revising in your brain. Okay, these are the things, or you can make your notes. You can make your own notes, whether in the form of audio or you can write. So, but the point is what I am trying to tell. Okay, let's arrived in intensive care unit 2 hours ago following cabbage. So you can think about what questions or what knowledge you should be knowing about cabbage. So cabbage is actually bypass, which is occurring with either off pump or on pump. And there are so many things which you should be knowing about it. Of course, what are the indication of cabbage? What are indication of emergency cabbage? What are complications for post cabbage? So few words you can think about: coronary artery bypass graft, and of course, with that, you can even expand it to the solutions which they are using or anything which they are using uh, during this cabbage. He has a background of interstitial lung disease. Okay. And hypertension. So another two diseases come. So again, I tell you that you did these points, the Rivian points or brainstorming points you have to bring. So what is interstitial lung disease? What are different causes of interstitial lung disease? What happens in interstitial lung disease? What are the changes in the physiology? So you need, because make it very simple. What are mechanical effects and what are biochemical effects? So there are something with reference to the lung compliance in interstitial lung disease, and there are some things which are related to the biochemical effects of it. Okay, and there will be certain things which are correlated either in the form of disease pathology or because of the treatment or coexistence. So interstitial lung disease is another buzzword for you. Hypertension, hypertension is our friend. Okay, so we know so many things about hypertension. He's intubated, ventilated, and sedated. So you can just see another, like you must be thinking I am crazy, but what are different reasons of intubation in ICU? Why patient is kept intubated post-operatively? So certain things, how to give the sedation, how to do the ventilation, just you can review. On an noradrenaline infusion of 0.05 microgram per kg per minute. So you can just think, what is norepinephrine, which receptors it acts, what are the effects, how to monitor, how much is the dose, whether it can be given through central line or peripheral line or PIC line, what are the problems? Okay. Atrial pacing wires are inside too. So again, our friend pacemaker has come. You're called to see him as the nurse looking after him thinks the ECG has changed. His blood pressure is 110 by 80 and cardiac index is 1.5. I think it's on the lower side. So now again, this will be another learning point initially, what is PICO? And another thing I will tell you that initially maybe you don't need to read the whole of the topic. If this word come and you are reading this MCQ and you have no idea what is cardiac index or what is PICO, just Google it. You will have few words about it. Okay. You will have some basic understanding about PICO. Okay. So pulse control or something like that. I'm very, not very, you are here, Safiullah, or you have gone? I think they have gone. Anyways, so what is PICO? So you can learn few words about it. How we use it, what are the advantages, what information we get. So PICO is another buzzword. And the readings an hour ago were 130 by 80, and cardiac index was 2.4. So it has gone down from 2.4 to 1.5. And his 12 lead ECG, they are showing it here. So what information you can get from ECG? What is the rate? It's a tachycardia. What is the rhythm? Is it sinus? Anyone, please? Is it sinus rhythm? Is the rhythm regular? Okay. So, um, not clearly identifiable. There is P waves. Okay. So it's not absent. You can say it's sinus tachycardia, or let's see what they will tell you. Okay. It seems atrial. Atrial fibrillation or
Regular,
SVT? Sorry,
regular rhythm.
regular rhythm. But what sort of arrhythmia it can be? Is it
Supraventricular
just
tachycardia.
yes, supraventricular tachycardia? But uh, there are some P waves. What do you think? This is not a very good ECG, but it is tachycardia. So let's see what it is. So here, and when you are reading from a soft copy, you can make it that in one mobile or your tablet, you can open one thing, and in the other mobile, you can open the other thing. So it is atrial flutter. Let's see. Let's come back how we are saying that it is atrial flutter. So what is the usual presentation of atrial flutter? It has sawtooth appearance. So is it sawtooth appearance? I'm not sure whether it is very. I it's not.
Lead, it seems all the
Sorry.
other leads are okay.
Yes, yes. In the limb leads, in this lead, you are saying Vajiha.
Yes, sir. This lead 2 and lead 3 somewhat shows atrial flutter pattern.
Okay, let's see. So up to 40% of CABG will develop postoperative atrial fibrillation or flutter. The majority of these dysarrhythmias occur within 48 hours and may be recurrent. Presence of atrial flutter is associated with an increase in hospital mortality as well as complication of stroke. So you can just revise the topic of atrial flutter or atrial fibrillation. Still, I say that this is not a very clear ECG in my opinion, in my observation, but maybe I don't. Anyways, so the risk factors for development of atrial fibrillation or flutter, when this question is being asked to you, specifically here, maybe answer is a little different, but there are certain causes, cardiac causes or non-cardiac causes, thyroid disorders, hyperthyroid, sepsis. There are certain conditions in which atrial fibrillation is very common. Okay. So it uh, here also atrial injury during cannulation, because they are specifically discussing about post ischemia, prolonged CABG time, bypass time, use of postoperative catecholamines, hypokalemia and hypomagnesemia. Although accompanied with reasonable hemodynamics, there is clearly fall in cardiac index as measured by PICO. Atrial flutter may change to atrial fibrillation and rate control is rarely an option. Restoration of sinus rhythm should be the aim in the circumstance and is best achieved with synchronized DC cardioversion. Although amiodarone is frequently used for atrial flutter, data concerning its use in this setting is surprisingly lacking. Um, you can, what the learning point will be, what is DC cardioversion, how it works, with what it is synchronized, what happens if it is not synchronized, okay, and then causes of atrial fibrillation, how it develops, atrial flutter, how it develops, and what is the management. You can just review the American Heart Association classification for it. Okay. So, okay. So when using amiodarone, cardioversion may take hours rather than minutes. When using amiodarone, cardioversion may take hours rather than minutes. Yes, so it is chemical cardioversion. So chemical cardioversion will take a lot of time. Here you will get it very quickly. Another reason to avoid amiodarone this circumstance would be the history of interstitial lung disease. Okay. So you see, they have correlated they put the interstitial lung disease with reference to amiodarone, because amiodarone is one of the medication which can cause interstitial lung disease, which is a risk factor for exacerbation of any lung fibrosis that may be caused by amiodarone. Rate controlling agents such as beta blocker and digoxin would not be optimal treatment here. Atrial pacing is a viable option, but would usually be performed at a rate 10 to 15 beat per minute higher than the atrial flutter rate. If the ventricular rate rises to match the atrial rate, the pacemaker frequency can be reduced. the rhythm is entrained when acceptable rate. This may lead conversion to sinus rhythm or atrial fibrillation. Given this patient is already sedated and ventilated, it is quicker and more effective to perform DC cardioversion. So you see how so many points say what are different options. So they choose atrial in this scenario the best option because it will be quick and the patient is already sedated and ventilated, so that's why it will be easy. As well as be addressing strategies for cardioversion, it is also imperative that other contributive factors uh, other contributing factors for the development of any dysrhythmias are addressed: hypoxia, hypercarbia, electrolyte imbalance, and other causes of myocardial ischemia, including the surgical cause. Okay, so yes, you see that's how you um, there are so many things which you can learn from this MCQ. Okay, let's go to the next. You are scheduled to anesthetize an 80 kg man for AVR. He is 73-year-old and reports a rash upon administration of penicillin. His skin swab is positive for MRSA. Which of the following antibiotic regime is most appropriate for the patient? So actually, this is with reference to bacterial endocarditis prophylaxis, and the patient is allergic to penicillin, and uh, the patient has a resistant MRSA. So actually, this is more related to microbiology, but the thing is that there is some cross sensitivity between the penicillin and uh, this one cephalosporins. But I think the answer here is they have written C, but I don't know how. So you can just see what is this flucloxacillin, gentamicin. The gentamicin is macrolide. Yes, Vajiha, do you remember? Erythromycin, gentamicin, I think they are uh,
Yes, sir. Macrotypes. Yeah.
macrolides. So ciprofloxacin is quinolones.
Those?
Yes, so fluoroquinolones, what is anesthesia relevance? One of them is important with reference to MCQ is fluoroquinolones causes QT interval prolongation. Okay, so let's see the answer. So that's okay. So I was right. So vancomycin, because there is cross sensitivity between penicillin and cephalosporin. So that's why I think they have not selected it. Common pathogen in cardiac surgery are Staphylococcus aureus or Staphylococcus epidermidis. In addition, this man has evidence of MRSA. So any prophylactic antibiotic must cover this organism, vancomycin or linezolid. Most centers also administer some gram-negative cover as such as aminoglycoside or fluoroquinolones. So actually, this was not the point which I was thinking. It's related to the bacterial coverage. So that's why you see anesthesia doctors, we should know everything. Although the skin reaction reported for penicillin may not be significant, it is prudent to avoid penicillins, thus flucloxacillin and coamoxiclav should be avoided. So that one, vancomycin with gentamicin provides a gram positive, including MRSA. So this is with reference to this question is with the so now you can what you can do, you can open Google and you can see that antibiotic coverage. Of course, this is related to microbiology. The dose of vancomycin 15 milligram per kg should be given as slow infusion. What complication occur with vancomycin? This red man syndrome occur with vancomycin?
Yes, I think Redman syndrome.
Yes. So dose of vancomycin, the combination of cefuroxime and metronidazole does not have MRSA cover. And although clindamycin with ciprofloxacin gives good gram-positive, gram-negative MRSA cover. The use of untargeted ciprofloxacin is often discouraged due to the speed by which plasmid-mediated resistance can occur. Other elements of perioperative care that may reduce the incidence of surgical site infection include patient warming. So you see, this is another very good point you can get. What are the factors which can increase the risk of surgical site infection? So this is another topic you can read from here, or you can explore from here. Warming, the glycemic control, hair removal, and sterility of instrument and the surgical field. So because this is another question, so the learning objectives will be with reference to empirical antibiotics for certain conditions and certain bacterial. And because again, I have this doubt that there is some cross sensitivity between penicillin and cephalosporin. So if you can avoid, you should avoid. But still, you will find two different school of thoughts. So this is about this question. 76-year-old woman who is spontaneously breathing through a temporary double lumen cuffed tracheostomy tube following a laryngectomy becomes acutely breathless. So what are the concerns here? It is with laryngectomy. So what are the things you can revise about laryngectomy, cancer, chemotherapy, radiotherapy, airway problems? So all things you can come into your mind. Through a temporary double lumen cuff tracheostomy, tracheostomy tube following becomes acutely breathless. Help is on the way, but despite application of high flow oxygen, her saturations are 82% with a respiratory rate of 40 breaths per minute. What is the most appropriate next step in her airway management? So actually, this question will be through the three things: the blocked tracheostomy tube and this one algorithm. Okay. So because all things can be done, but what you will be doing, the first will be the the main point. So let's see what they have written. Remove the inner cannula. Remove the inner cannula. So the tracheostomy airway emergencies can lead to significant morbidity and mortality if not managed correctly. Laryngectomy patients do not have an upper airway. So upper airway is bypassed, critically cannot be intubated or oxygenated orally. They are unlikely to obstruct when lying flat, so sitting them upright is not the immediate airway priority because it will not help a lot. In this scenario, but still, now my counter argument, if you have a patient with respiratory difficulty, if you make upright, it will decrease the abdominal pressure, so FRC will improve. So this is one dimensional thing. If they are talking with reference to airway obstruction, so here the point is not with reference to the FRC or belly contents. This is with reference to airway obstruction. Usually when we make head side up, actually it decreases the obstruction by releasing the pressure up, going up towards the pharynx and upper airway. So this is the point which they want to highlight. In this scenario, following a call for help and application of oxygen, the tracheostomy tube patency needs to be assessed as a priority. So that's why they want to remove the inner tube. With double lumen tracheostomy tubes, the initial step is to remove the inner tube, which will clear any secretion if these are causing a blockage. Following inner tube removal, passage of a suction catheter should be attempted to confirm airway patency and also help clear any further secretions within the tracheostomy. If the suction catheter fails to pass, deflation of the tracheostomy tube cuff may improve airflow if the tracheostomy tube is partially displaced. Okay, so this is another point. If the clinical condition fails to improve following cuff deflation, the tracheostomy tube may be completely blocked or displaced, preventing the patient to breathe around the tube adequately and should therefore be removed. So they are telling you one by one what you should be doing. Uh, Preventing the patient to breathe around the tube, attempting hand ventilation through a tracheostomy tube, confirm airway patency is hazardous since significant surgical emphysema can ensue in the presence of double of the tube displacement, making subsequent airway management more difficult. Okay, so if you are giving positive pressure ventilation, the emphysema can be increased or can occur. Provide a graphical suggestion. So that's how you patient does not have an upper airway, so it's discontinued. Remove the inner tube if present. Attempt to pass the suction catheter. If unnecessary, deflate the cuff. Look, listen, feel at the tube. If the patient retreats, remove the tube. Okay. Therefore, this patient requires removal of for further assessment and management of the cause of her respiratory distress. So actually, the learning points for you that you can have open. There is an algorithm for tracheostomy block, tracheostomy tube. So you can review that. And again, I tell you something that call for help, 100% oxygen, or what you need should be doing is the priority. The question, the way they have asked will be like, for example, maybe the next step answer is different and the best step will be different. Okay. What do you think? What if practically if you are not maybe the best option at that time there are certain things which you can do. They are saying removal the inner cannula and doing the suctioning. That's that we are making point. Okay. In some people will also try to remove the tracheostomy tube altogether and reinsert if it is not a recent one. Otherwise, you will go step by step. If it is a long one, maybe practically you can remove the tracheostomy tube, deflating, removing it, wash it, or if it is blocked, you will come to know, and then you can reinsert it. Or another option will be that if stoma is already prepared, or if you have any doubt about the tracheostomy tube, you can ventilate with the mask, or you can see the improvement what occurs when even if you have removed it. So again, this so many things which you can learn from this point. So I will stop here, and because uh, we will be trying to make a formal uh, course or formal, but the purpose of today's discussion was that how you should read from MCQs. What should be your learning point? If there's some people who have joined late, I will again suggest you that retrospective learning is the best way to learn, number one. Number two, if you are reading any MCQ, try to go point by point and try to explore what is the reason, like some more exploration here. What is the differential diagnosis of tachypnea? What is the differential diagnosis of hypoxia? Not only here. What about high flow oxygen? What are different ways by which you can give high flow? So another revision point for you will be what are different ways to give the oxygen therapy. Okay. So this will increase your learning. And also I told you that if for example, it's 76-year-old woman, so revise about elderly. Okay. So that's how you can increase your knowledge gradually. If you are only looking for the answer, maybe apparently you will solve the problem, but ultimately you will not have that much benefit. So another point I will suggest you that once you have read a MCQ book, don't revise in a way that you are just recalling the questions. You should recall the points. So this is another thing which you should be thinking. Extract the points or learning objectives from any MCQ and then translate it into uh, what are the things you should be extracting from it. Okay, so that's how you should go with it. Okay, so thank you very much, and we will continue our sessions, inshallah. Bye bye.
Hmm? Oh,